We first want to talk about leukocytosis, which means increased white cells in the blood. So there can be increased bone marrow production, typically seen with acute inflammation associated with pyogenic bacterial infection, as well as tissue necrosis. Increased release from bone marrow storage pool, typically caused by corticosteroids, stress, or endotoxin. Increased bands, left shifts, or shift to the left is characteristic. As far as reactive changes, the doily body's toxic granulations are typical things that you will see. Here's a peripheral smear of a doily body inside this band cell. Now, with increased eosinophils or eosinophilia, typically associated with allergic reactions and parasitic infection. You can see it associated with drugs and certain skin diseases, but you want to know that it's definitely associated with allergic reactions and parasitic infection. With your increase in monocytes or monocytosis, typically seen with things like collagen vascular disorders and inflammatory bowel disease. Infections like TB can also have these increased monocytes. Of course, with TB, we call them macrophages inside the tissue. With increasing your lymphocytes or lymphocytosis, associated with a viral infection, remember lymphocytes attack viruses, as well as seen with chronic inflammatory processes. Now we talk about infectious mononucleosis. It's a viral disease associated with increase in lymphocytes, caused by Epstein-Barr, which is a type of herpes virus. Less common causes are other viruses associated with heterophile negative infectious mononucleosis, and most likely due to CMV. However, with CMV, the clinical manifestation is a little different, and we'll get to that. Now, the sequence of events, the Epstein-Barr virus will invade the B lymphocytes via the CD21 receptor. Now, cytotoxic T cells respond against the invaded B cells, and they actually form these atypical lymphocytes. Now, because they're large and have abundant cytoplasm, they look like monocytes, ergo the term mononucleosis. But remember, very typical T cells and not monocytes that you're going to see on the peripheral smear. Sometimes they have the so-called ballerina skirt appearance. Why is that? The red blood cells around the atypical lymphocyte will indent the cytoplasm and the nucleus like this, and give you that, sort of kind of ballerina skirt appearance. You ever seen that movie, The Sound of Music, with Julie Andrews? She's kind of twirling around, that kind of thing. Now, as far as your antibody production, the heterophile antibody, which is a cold antibody, typically produced, and we use a monospot test to identify it. May be negative early, so make sure you want to repeat it if you think the person has infectious mononucleosis. Now, typically associated with kissing disease, so your typical patient is going to be someone in high school or college. Your classic presentation is going to be fever, sore throat, and bilateral cervical lymphadenopathy. Now, CMV can give you a mono-like picture, but remember, with CMV, there is no sore throat. There's no sore throat with CMV infection. The disease, though, is acute and self-limited and resolves within a few weeks. However, it may be associated with hepatic dysfunction, splenic rupture, and rash if treated with ampicillin. Now, moving on with leukocytosis and increasing basophils, so-called basophilia. Typically, you don't see increase in basophils. However, you can see it with myeloproliferative disorders, classically polycythemia vera, as well as CML may also have increased basophils as well. Now, leukopenia means decrease in white cells in the blood. Again, the suffix penia means decreased in the blood. So, why would you have decrease in white cells in the blood? Well, with neutrophils, it can be associated with decreased production, such as aplastic anemia, which they like, and chemotherapy. It can also have increased destruction from infections and autoimmune diseases like lupus. You can also get activation of neutrophil adhesion molecules on the endothelium, typically endotoxins and septic shock is a classic thing you will see. As far as your decrease in eosinophils, increased cortisol associated with diseases like Cushing syndrome as well as exogenous steroids can cause it. Now, as far as your decreased lymphocytes, this can be seen with disorders like HIV, DiGeorge syndrome. This one is going to be our hypoplasia of the thymus. Remember, lymphocytes mature in the thymus, so you're going to have viral infection because of the T cell deficiency. SCID, also associated with decrease in both B cells and T cells. Again, immune destruction, like with lupus. Steroids, again. Radiation is also a common thing that can do it. And you can have atypical lymphocytes found in the peripheral blood and T cell areas of lymph nodes. This is a classic schematic of a normal lymph node showing you our outer cortex. Now notice how the follicles are found in the cortex. Okay. In the medulla, we have your sinusoids. You can see here. Okay. Notice we also have the pericortex where the T cells reside. And of course, inside the follicle, we'll have the B cells. Now, get used to this architecture of the lymph node because when we talk about lymphomas, one of the things you're going to see microscopically is effacement or disruption of this architecture. This is also very important when we talk about our follicular lymphoma because with the follicular lymphoma, you will have follicles, but the key is the follicles will be found within the cortex as well as within the medulla as well. Normally with a lymph node, the follicles should only be in the cortex. Now, when we see the term lymphadenopathy, that means enlargement of the lymph node. It can be secondary to infection. It could be a reactive condition, or it could be neoplastic in nature. So we talk about our acute, nonspecific lymphadenitis. We're talking about acute inflammation of the lymph node. It's going to be large and it's going to be tender. Why? Because of your cardinal signs of acute inflammation. So on the exam, you get the history of a tender lymph node, think acute inflammation and bacterial infection. Microscopically, of course, you'll see neutrophils in the lymph node. Okay. Cat scratch fever can be associated with stellate microabscesses. And of course, when you have viral infection, you'll have generalized involvement of the lymph nodes. Now, with our chronic, nonspecific lymphadenitis, you're not going to have a non-tender enlargement of the lymph node. So, of course, you want to differentiate this from a neoplastic condition, which can also be non-tender. For our non-neoplastic or reactive conditions, we have the follicular hyperplasia. Typically involves the B lymphocytes, may be associated with toxoplasmosis or rheumatoid arthritis and HIV. You can also have pericortical lymphoid hyperplasia involving the T cells and can be seen with things like viruses and drugs, again with lupus. However, I will caution you with the so-called sinus histiocytosis. Now, remember, the histocytes in the lymph nodes are the macrophages of the lymph node. So what we're saying is you're getting dilated sinusoids filled with histocytes. And this is a reactive condition secondary to the lymph node draining a cancer. So the point is, if a person has lymphadenopathy and also has cancer, you cannot assume the enlarged lymph node is metastasis. It could be sinus histiocytosis, a reaction of the lymph node secondary to the tumor. Now, as far as our neoplastic conditions, you're going to have non-tender enlargement of the lymph node. So very important, you're going to differentiate whether the enlargement is neoplastic or not. Now, most commonly, if it's neoplastic, it's going to be a metastatic cancer. Okay. Typically, when a metastatic cancer goes to a lymph node, the first place it goes will be the subcapsular sinus, okay? Again, right underneath the capsule. So that could be a histology question they could ask you on the exam, okay? However, lymphomas also can involve the lymph node as well as leukemias.